Hello, very good evening, dear students. I hope some of you are here. I hope I'm audible. So I want you to put in the chat box if I'm audible or not so that I can proceed with the session. Please let me know if I'm audible by putting in the chat box. Okay, thank you for the response, and once again, very good evening to all of you, those who are here with me in the live session. So, my name is Dr. Radhika, and I am the NEET PG educator for the Medicoz Community Platform. So I believe all of you are medical students in the different years, and community medicine is the subject that you study in your second year and third year mostly. But in order to face the exam, the competitive exam, which is the NEET now and upcoming next, you need to be in touch with the subject till the end of your house urgency. So Medicoz Community Platform has an offer for you. If you go to the website, there is the early bird offer, which you can avail, which will help you prepare for the upcoming or the newer version of NEET, which is the next PG exam. Okay, with that, by availing this offer, you will be able to reach your goals that you have set for your future. So what I'm planning to do today is we will be discussing the high yielding questions in community medicine. So I have about 25 easy to moderate questions but very important concepts in community medicine which are must knows before you attempt your NEET PG exam. So I have 25 questions with me which I'll be discussing with you today. I will be discussing the concepts of each question in detail and also going into what are the other types of similar questions that can come from that concept. Okay, so that is the plan. I hope all of you will be with me throughout the session, and please feel free to put in the chat box if there are any technical issues or if you have any doubts, or certainly if you want to answer the question before I say the answer, please put the option in the chat box so that I know how many of you are with me, how many of you have doubts. Okay, so I hope I'm going to proceed to the session. I hope all of you will be with me till the end of the session. Okay, so I'm moving on to the first question. Okay, so the question is, the population of an area is 8,000 and 700 new cases of tuberculosis was detected. The population already had 250 known cases of tuberculosis. What is the prevalence of TB in this population? And the options, as you can see, are in percentages. Option A is 10.2%, option B 11.8%, option C 8.7%, and option D is 3.1%. Okay, so here I know many of you get worried when there are some numericals or when there are some numbers in the question, but this is a very simple question and I can explain it to you so easily that if any question comes in the concepts related to this, you'll be able to answer them. So we have three values here. The first one is the population of an area, which is 8,000. Then we have new cases of TB, which are 700, and we also have 250 known cases of TB. So the concept that I'm going to discuss here are mainly two. That is, one is the incidence. The term that you should know is incidence. and the second term is prevalence. Okay, so incidence is actually the new cases that comes up in the population. New cases is incidence, and prevalence is the total number of cases. So total means old plus new cases. Okay, this is the main idea or the concept that you need to know when you answer this question. And of course, prevalence has to be calculated as a rate. Okay, so there's a formula that you should know. So the formula is prevalence rate equals the total cases. That means old plus new cases divided by the media population into 100. Okay, so that is the formula for prevalence rate. Total cases, which is old plus new, divided by the media population. So when we want to represent in percent, we put this into 100. So here we know that the total cases includes the old cases, which is 250, and the new cases, which is 700. So which comes to a total of 950 in the numerator, and the denominator is the population, which is very simple, which is 8,000. And when you multiply by 100 in order to get the percentage, the value that you will be getting is 11.8%. Okay, so this is a very easy question where you have to calculate the prevalence rate, and the formula is the only thing that you need to know. That is the total cases divided by media population into 100 is the prevalence rate. Now suppose the question is to find the incidence rate. Okay, suppose the question is to find the incidence rate. What happens? What is the difference that is going to come? Anybody? If there's anybody who can get the answer to this, how do you find the incidence rate? Please let me know in the chat box. Yeah, so actually incidence rate, we need only the new cases. So the numerator will be only the new cases, and the denominator will be exactly the same, which is media population. And again we have to multiply it by 100 because the incidence rate also has to be represented in percentage. So that is the only difference. The numerator is the only difference that will come if the question is on incidence rate. Okay, so the concept that we are discussing here is incidence, which is the new cases, prevalence, which is the total number of cases, which is the old plus new. And when you want to find the prevalence rate, you divide the total number of cases by media population and represent it as a percentage by multiplying into 100. So any question, any similar question, if it comes up, you should be quickly able to do it because you know the formula and you know the concept. Okay, so moving on to the answer, you know that the option that we got is option B, which is 11.8% is the right answer to this question. Option B is the right answer. I hope that is clear. The concept of incidence and prevalence is something that you learn in the first to second chapter of Park textbook. Okay, so you know that that is a basic or the first thing or must know for any student who has studied SPM and to clear SPM. So I'm sure you're familiar with the concept and you're thorough with the concept now. So with that, we'll move on to the next question. So the next question is, the difference between descriptive studies and analytical studies include. So again, there are four options. Option A is, analytical studies help in understanding the distribution of disease. Descriptive studies are used to test a hypothesis. Option C, analytical studies are used to formulate a hypothesis. Option D, descriptive studies are first phase in epidemiology. So you know that this is again a high yielding topic from the area of epidemiological study designs. Okay, so how can I not take 25 MCQs and not discuss the epidemiological study designs, because this is the very important and most important thing in epidemiology and SPM. Okay, so how do we go about dividing the study designs, or how are the study designs classified? That's what I'm going to be telling you. So quantitative study designs, as you can see in the picture, are classified into observational studies and experimental studies. Okay, so observational studies, experimental studies are the main broad division of quantitative study designs. Again, observational studies are divided into descriptive studies and analytical studies. Okay, so descriptive studies and analytical studies is what our question is on. So I'll tell you a little bit about what descriptive studies are and what analytical studies are. So the first point that you need to know about descriptive studies is that any descriptive study is actually the first step in epidemiology. So the first step or the first phase of an epidemiological study is actually a descriptive study. Okay, so the first step in epidemiology is a descriptive study. That is the first point. The second point about descriptive study is that a descriptive study helps us to formulate a hypothesis. Please note this point. A descriptive study helps us to formulate a hypothesis. Okay, formulate a hypothesis. That is the second point that I wanted to discuss. And also a descriptive study, the third point is that a descriptive study helps us to understand disease distribution. Okay, disease distribution. That means if you want to identify how many diseases, how much of the disease is there in a population, then you need to first do a descriptive study to proceed forward with other concepts that may help you in finding causation and all. So disease distribution can be found using a descriptive study. Okay, so the 3 points about descriptive studies. The first one is that it is the first step in epidemiology or in any epidemiological study. The first step will be a descriptive study. Second point is that a descriptive study helps to formulate a hypothesis. And the third point about descriptive study is that it helps in identifying disease distribution. Okay, those are the 3 important points about descriptive studies. Whereas analytical studies, which is the other type of observational study, analytical studies are used to test hypothesis. Okay, the analytical studies are used to test hypothesis. And these are the second or the third steps in any epidemiological studies. So analytical studies are used to test hypothesis, and it usually comes after a descriptive study. So it will be the second or the third step. Okay, so these are some of the points, important points that you should keep in mind before answering this question. And I want to go a little more about observational analytical study. So the examples of observational analytical studies, very important 4 examples. The first one is a cross-sectional study. The second one is a case control study. The third is a cohort study. And the fourth, we have ecological studies also. So when we have further classes or further sessions, we will have a single class itself on the multiple questions that are possible from epidemiological study design. So then we can be discussing each of the study designs in detail. Okay, so with this much idea in mind, let us go back to our MCQ and find out what is the right answer, or let us rule out the wrong answers, which will be more helpful for you when you're answering questions. So the difference between descriptive studies and analytical studies include, the first option is analytical studies help in understanding the distribution of disease. Okay, is it so? Is analytical study helping in understanding distribution of disease? So we discussed that when we spoke about descriptive studies. So this is wrong. Descriptive studies help in understanding the distribution of disease. Okay, I hope that is clear. Again, the second option is descriptive studies are used to test hypothesis. So I told you descriptive studies are used to formulate hypothesis and analytical studies are used to test hypothesis. So in this, the options have been put in the wrong way so that you get confused, but you should be very clear. Descriptive studies formulate hypothesis. Okay, so the option B is also wrong and option C is also wrong. And the last option is descriptive studies are first phase in epidemiology. Yes, it is the first step or the first phase in epidemiology are the descriptive studies. So that is the right answer. Answer D. Okay. So if you have any doubts in this descriptive or analytical studies, you can be putting in the chat box. We can clear your doubts. If not, we'll move on to the next question. So once again, descriptive studies, observational analytical studies are very, very important concepts. So I have one more question from that part. And this is also a very important question which can come as a repeated question in many ways by just tweaking the disease or the situation that is there in this. So the question is this one, the third question. Okay guys, third question. A study was done to determine the relation between smoking and COPD. Patient data was collected from government hospital records and sale of cigarette data from finance and tax departments. What type of study is this? Okay, so here it's a very important concept that I want to bring out. That is, the patient data here was collected from government hospital records. Okay, so when we go for data collection, there are two types of data collection. One is the primary data and the other one is the secondary data. So if you have done the students, you will be doing your projects in your third year in community medicine. So you know that you will be doing data collection mostly by going to the people, speaking to them, interviewing them, getting their data. So that is called primary data, when you directly interview people and get data from their mouth. Okay, so that is primary data. Whereas when you take data from records, okay, when you take data from records, that is called secondary data. Okay, so secondary data is what is used in this study to determine the relation between smoking and COPD. That is the first point that I want you to know. Secondary data is the one. Now we'll go through each of these study designs to understand what could be the answer in this. So cross-sectional study is the first option. So cross-sectional study is actually a study that is done at a point in time where you go to people. Most of your projects will be cross-sectional studies where you go to people, collect data about them and then analyze them and bring up the reports. So cross-sectional study is actually using primary data. So that is not the option. Again, case report. Case report is actually something that happens when a rare case is reported in a hospital. Immediately that can be, the details of that case can be written down and published officially in good journals. So that is a case report. Okay, so case report is again primary data. It is not from records. Okay, it's primary data from the patient itself. The third option is operational research. So this might be a new term for you. So operational research is something that is done in order to bring in newer ideas for any program implementation. So if they want to implement a national program, they will be doing something called operational research to implement the newer idea. So again, that is actually primary data is used in operational research. So that is not the answer. So the pending one is the ecological study. So ecological study is the one that uses secondary data. So I want to say a little more about ecological studies. Okay. So a few points about ecological studies. If there are people who are taking notes with this, please make sure that you write down these points that I'm saying about ecological study design, because this is something that keeps coming for your NEET PG exam. So ecological study, the first point that I want to write is what we have already discussed, that it uses secondary data is used in ecological studies. Another point, what type of a study is it? That also we had discussed previously. We had discussed when we discussed a classification of quantitative study designs. We said that ecological study is an observational analytical study. Okay, observational analytical study. That is what an ecological study is. Okay, that is the second point that I want to discuss. And the third point, the unit of study in an ecological study design is actually population. Population is the unit of study here. And the other terms for ecological studies include correlational study. Ecological study is also known as correlational study or geographical study. Okay, geographical study. These are the other terms used for ecological study. So once again, I want you to know a little more details about ecological study. It is an observational analytical study. It uses secondary data, which means from the records. The third point is that the unit of study is population. And the other terms for ecological studies include correlational study and geographical study. Okay, so these 4 points, they can come as questions. Okay, what type of a study design is ecological study, or like the question that is asked here, it uses secondary data. What is the unit of study in an ecological study? Any of these can come as a NEET PG question. And one more term that I want to introduce here is called ecological fallacy. Students, ecological fallacy, this is something very important, not there in your PARK textbook, okay, but it can come for exam. Ecological fallacy, it means falsely inferring what is true for the group or population is true for the individual. So from an ecological study, you get a result for the population, because our unit of study is population. And we might feel that, okay, this result is true for every individual in the population, which may not be so. So that is called ecological fallacy, which means there's a small mistake when we interpret the result of the whole population to each individual. An example I can tell you. So it is seen that coronary heart disease is common in rich cities. Okay, coronary heart disease is common in rich cities. Okay, that is something that we have got or previously got from an ecological study. So does it mean that rich people are more prone to heart disease? So we try to interpret it like that, no? Rich people are more prone to heart disease. Is it so? It may not be, right? It may not be. So this is what is called an ecological fallacy. So what is understood for the whole population, when we try to extrapolate it to one or two individuals in the population, it may not be true. So that term is ecological fallacy. Students, I hope you are with me. I hope you are understanding what an ecological study is and what ecological fallacy is. So this concept of ecological study can keep coming for exam. So the answer here was answer D, ecological study, where they derived their data from the records. So that was a clue that we had. So it was secondary data and hence ecological study. Okay. So that's about ecological study. Moving on to the next question. If you have any doubts, please put in the chat box. Suraj has asked, what type of questions come in ecological study? Yes, Suraj, that's what I was saying. The type of data used, what is the unit of study, what are the other names for ecological studies, what is ecological fallacy. These are the high yielding part in ecological study. So these are the areas from which questions can come. So all of the following are true about ecological studies except. So if you're clear about all the concepts that I told you, then you will be able to answer them, Suraj. I hope I have told you enough about ecological studies. Okay, moving on to the next. The next question is again from the epidemiological study design. One more question from the analysis part. Okay, so the relative risk of a study was calculated to be 1. This indicates option A is negative association, option B is positive association, option C no association, and option D is none of the above. Okay. So relative risk is the term that we are concerned with here. Guys, I hope you know where is relative risk calculated, in which study design is relative risk calculated. That is the first thing that we should be knowing. In which study design is the relative risk calculated? Yes, it's calculated in a cohort study. Okay, so a cohort study design, when we are analyzing, we get what is called relative risk. Okay, can you tell me what is relative risk, or what is the formula for relative risk? That is what we need to know. Relative risk means incidence among exposed people, incidence among exposed people divided by incidence among the unexposed. Okay, that's a very simple formula but very important term, relative risk. So first point that you should know is relative risk is calculated in a cohort study. The second point is relative risk formula, which is incidence among exposed divided by incidence among unexposed. So that is the formula for relative risk. Now, the next concept that I want to discuss in order to answer this question is, what is the interpretation when relative risk is greater than 1, is equal to 1, and when relative risk is less than 1. Okay, so what is it, students? When relative risk is greater than 1, what does it mean? Okay, so here I have it. Relative risk greater than 1 means a positive association between the exposure and the outcome. Okay, so relative risk greater than 1 means a positive association between exposure and outcome in a cohort study, whereas relative risk equal to 1 means there is no association, okay, note the point. And relative risk less than 1 means negative association, okay, negative association between the exposure and outcome. So this is something very important that you should know. What is the interpretation when relative risk is greater than 1, equal to 1, or less than 1, okay. So relative risk greater than 1 is positive association between exposure and outcome. Equal to 1, there is no association, and less than 1 is a negative association. So shall we go back and see the options? Yes, so here we have relative risk was calculated to be 1. The 1 is hiding there, but you have to open your eyes and see that relative risk was equal to 1. So what is the answer? There is no association if relative risk is equal to 1. So the answer is option C. Okay, I hope all of you have understood what relative risk is, where is it calculated, which study design, what is the formula for relative risk, and what is the interpretation when relative risk is greater than 1, equal to 1, or less than 1. Any doubts, any doubts for anybody? You can please let me know. So the answer is option C. Relative risk equal to 1 means no association. Once again, we can discuss more about cohort study and other results of analytical or cohort study design results in the upcoming sessions of SPM classes. Okay. So, yes, good. There were people who have put right answers before me. Simran, good. No association. Option C, that was the right answer. Yes, good. I've understood that many of you are with me. Okay, we'll keep going. Going to the next question. Question number 5. Okay, so a 45-year-old man came to the OPD for health checkup after his father passed away after suffering from uncontrolled hypertension and massive MI. The son was diagnosed to have hypertension during this checkup. What level of prevention is this? Okay, so there's an old man who has passed away at the age of 45. He's not old. 45-year-old is too young to have uncontrolled hypertension and massive MI. But the person has passed away and his son decides to go for a health checkup and he gets diagnosed to have hypertension during that visit. So what level of prevention is this is the question. If there are people who know the answer, you're free to put in the chat box. So before I tell the answer, we'll discuss about the levels of prevention. Okay, levels of prevention. So the first is the primordial prevention. The second is primary. The third is secondary prevention, and then there is tertiary prevention also. Okay, primordial, primary, secondary and tertiary prevention. So I want to tell you what each of this means. So primordial prevention, first of all, it means that the risk factor for a disease is absent. The risk factor itself has not appeared in a person, and the disease certainly has not appeared in a person. So risk factor is not present, disease is not present. So you're trying to prevent the development of risk factor. That is what primordial prevention is. Typical example that I want to give you is when we give health education to children. So children are the focus for primordial prevention. So when you teach children that sedentary lifestyle or physical activity is important in getting obesity in future, that is primordial prevention for cardiovascular disease. Okay, so you're teaching children that becoming obese or having a good physical activity will help them prevent obesity as adults. Right? So when you're teaching them about good physical activity at childhood itself, that is primordial prevention. So there is no risk factor, there is no disease, and you're preventing the risk factor from developing. That is primordial prevention. Okay, that is the best level of prevention, I should say. The best level is primordial prevention, and it is focused on children. Now, the second type is primary prevention. So, primary prevention is when the risk factor is present, but the disease has not yet occurred. Okay, risk factor present, but the disease is still absent. Okay, so again taking the example of obesity and cardiovascular disease. So an obese person who has not developed any of the lifestyle diseases, when we are advising him physical activity to reduce his weight, that is an example of primary prevention. So the important thing that you should remember is the risk factor is present, but the disease is absent when you're doing primary prevention, and you do not want the disease to develop. Okay, so that's when you do primary prevention. Again, another example that I can be giving is folic acid in pregnancy. Okay, folic acid in pregnancy is a typical example of primary prevention. Typical example of primary prevention where you're trying to prevent neural tube defects. So there is risk factor of developing neural tube defect, but when you're giving folic acid, it's called specific protection. You're giving folic acid as a protection to prevent the disease, which is neural tube defect. Okay, so that is again an example of primary prevention. Students, I hope you are with me. Yes, Abhishek has told the right answer. Good. Okay, if there are more people who know the answer, please put in the chat box. Okay, so we finished primary prevention. What is secondary prevention is when the risk factor is present and the disease is also present, and we are trying to pick up the disease early, which means early diagnosis and treatment. Okay, early diagnosis and treatment is secondary prevention. So your screening procedure is actually secondary level of prevention. So this is a usual question that can come. What level of prevention is screening? It is secondary prevention. Okay, so when you're diagnosing or picking up the disease early, the disease is already present, the risk factor is present, so it's secondary prevention. Now the last is tertiary prevention, where the disease is present and its complication. We are trying to do disability limitation and rehabilitation because the complication has also developed. Okay, complication is also developed. So disability limitation and rehabilitation is what tertiary prevention is. Disability limitation and rehabilitation. Students, I hope you are with me. Primordial, primary, secondary and tertiary prevention, what each one is with examples we have discussed. I also want to tell you there's one more level of prevention called quaternary prevention, okay, which is not there in your textbook, but yes, you should know. What is quaternary prevention? Anybody? Quaternary prevention? It is actually preventing the effects of over medication or over treatment. Okay, so over medication or over treatment can lead to certain side effects or complications in the people. So preventing over treatment or over medication is what quaternary prevention is. I hope that is clear. Now with this idea in mind, let us go back to the question. Which level of prevention was that man doing? Primordial, primary, secondary or tertiary? Yes, like Abhishek said, very good. The son was diagnosed to have hypertension during the checkup. That means here the disease has already come up and they have picked up the disease early. So which level of prevention is that? That is secondary level of prevention. Okay, so there was right answer, Abhishek. Good. Secondary prevention. So early diagnosis and treatment was secondary prevention. Okay, students. So levels of prevention very important for your theory as well as for NEET PG. Okay. Moving on to the next question. The next question is, denominator for the calculation of sensitivity is option A, total number of diseased individuals. Option B, total number of healthy individuals. Option C, total number of subjects with positive result. Option D, total number of subjects with negative result. So in order to understand this concept, you know that sensitivity, specificity and all are terms that you are very familiar but often get confused as to what is the formula, how do I go about answering this. So I'm going to make it very simple for you. Okay, so in order to understand what it is, we have to first draw the 2 into 2 table. Okay, there is a 2 into 2 table that we draw in order to understand sensitivity and specificity. Okay, so the exposure or the test will be coming on the left hand side in the rows, and the columns will have the outcome or the disease. Always remember the outcome will be in the columns. Okay, so test present, test absent, disease present and disease absent. Okay, and how do we write what happens in each cell? The number will be A, B, C and D. So once you are able to construct this 2 into 2 table, then your sensitivity, specificity and all are going to be very, very easy. Okay, so let's see what sensitivity is. so that we derive the equation from this table. Okay, so first sensitivity. So sensitivity very simply means true positives. Okay, sensitivity means true positives. So sensitivity is the ability of a test to identify the subjects who actually have the disease. Okay, so ability of a test to identify the subjects who actually have the disease. So among all those who have the disease, how many have tested positive? Those are the true positives. So can you tell me what formula will come for sensitivity from this? Among all those who have tested positive. So all those who have tested positive, okay, I will write the sum up also so that we know what the denominators are. Okay, so among all those who have the disease, how many are tested positive is the sensitivity. Okay, so among all those who have the disease means the denominator is all those who have the disease, which means A plus C is the denominator. Okay, all those who have the disease is the denominator, and the true positives is actually A. A will be the number of people who are identified positive by the test. So the number of people who are identified positive by the test divided by the total number of diseased people when represented as a percentage. That is what sensitivity is. So the formula very simply is A by A plus C into 100. The denominator is the total number of people with the disease. Okay, that is sensitivity or true positives. Now the second term all of you need to know here is specificity. You know, right? Specificity, the term. Sensitivity, specificity is the second one. Specificity means true negatives. Okay, so what will the formula be? True negatives means out of all the people who do not have the disease, how many have been tested negative? Okay, so let's write it down. Out of all the people who do not have the disease means B plus D. Okay, out of all the people who do not have the disease, how many have been tested negative? D is the numerator. Okay, that is true negatives, and of course it has to be represented in percentages, students. That is very important. Many of you will miss this 100, so that is not acceptable. Sometimes the option may be there without the percentage, which is not right. So specificity is D by B plus D into 100. There are two more terms that you need to know, that is positive predictive value, and the second one is negative predictive value. Okay, negative predictive value. Positive predictive value and negative predictive value. This means that out of all those who are tested positive, how many actually have the disease? That is positive predictive value, and that is actually the diagnostic ability of a test. The positive predictive value is actually the diagnostic ability of a test. So out of all those who have been tested positive, which is A plus B, you can see here, out of all those who have been tested positive, which is A plus B, how many have been actually positive, actually have the disease? So that is again A. So A by A plus B into 100 is the positive predictive value, which is the diagnostic ability of a test. Similarly, negative predictive value. Out of all those who have been tested negative, how many do not have the disease? So out of all those who have been tested negative means C plus D, and those who do not have the disease is again D, and you have to multiply by 100 like I told you before. That is negative predictive value. So I hope this is easy. You have to draw the 2 into 2 table and learn so that it becomes easy for you. Only when you draw this table and put in A, B, C, D in the right places, you're going to get the sensitivity, specificity, positive predictive value and negative predictive value right. So once again, going back to the question, they have asked what is the denominator of sensitivity. So sensitivity, let's see what is the denominator, what are the options that are there. Those who have put in the chat box. Okay, so the total number of subjects with the disease or total number of diseased individuals are the people who will be the denominator for sensitivity. Okay, so that is a direct question if you know the formula and if you are able to draw the 2 into 2 table. So that was about sensitivity, specificity. Next question is again a direct question from what I have explained till now. The diagnostic power of a test is reflected by option A is specificity, option B is sensitivity, option C is positive predictive value, and option D is attributable test. Okay, so specificity actually means the true positives we have discussed. Sensitivity is the true negatives. Sensitivity is the true positives and specificity is the true negatives. We have already discussed that, and we also discussed that positive predictive value is the diagnostic power of a test. Okay, positive predictive value is the answer. The diagnostic power of a test is shown by positive predictive value. And attributable test, okay, so attributable risk is something that comes up in the cohort study, and we'll be discussing that in the cohort study design. So the answer here, students, is positive predictive value. So the diagnostic power of a test is reflected by option C, that is positive predictive value. Okay, moving on to the next question, which is from the contraceptives. The 8th question is, the contraceptive X is used by 200 couples continuously for 5 years. In this period, 25 women had accidental pregnancies. Calculate the Pearl index of the contraceptive. Okay, so Pearl index, students, it's a very, very important topic. It keeps coming. Calculation of Pearl index keeps coming for exam. So please make sure you know what the concept is, what the formula is. Okay, so what is the formula for Pearl index? That's what we're going to be discussing. So Pearl index is the number of accidental pregnancies divided by total exposure into 1200. Okay, so number of accidental pregnancies divided by total exposure. So total exposure will be obtained by multiplying the number of years of exposure into the number of couples who have been exposed. Okay, so number of couples who have been exposed. Yes, many of you have put up the right answers for the previous questions. Ragini, good, that was the right answer. Yes, so Pearl index is number of accidental pregnancies divided by the total exposure, which is the number of years of exposure multiplied by the number of couples exposed, and the whole thing is multiplied by 1200, which is actually the total, because the Pearl index, the unit of Pearl index is per 100 woman years. So we multiply by the total months, that is 12 months are present in 100 years. So 12 months into 100. That is how we get this 1200. It is a constant value that you should be using when Pearl index questions come. The only change that will come is number of accidental pregnancies will be different. The total exposure will be different. So students, please calculate and tell me what is the answer in our question. So we have 25 accidental pregnancies here, which is the numerator, and the exposure will be number of years of exposure, which is 5, multiplied by the number of couples, which is 200, and the whole thing is multiplied by 1200. Okay, that is the answer. How much will you be getting? So when you calculate this, you will be getting option of 30 per 100 woman years. Okay, 30. So your answer is C. So if you know the formula for Pearl index, it's going to be direct. You just need to find the accidental pregnancies and divide by the exposure, which is number of years into number of couples, and the whole thing is multiplied by the constant of 1200, which is the number of months in a year into 100, because 100 woman years, the unit is 100 woman years. That's why we are multiplying by 1200. I hope that is clear. Please, those who have understood, if you have any doubts, you can put in the chat box. I can see that many of you are responding with the right answers to the questions. Good. So that was about Pearl index. Next is a very direct question from the WHO guidelines. So what is the cutoff for low birth weight according to the WHO? So low birth weight. So this keeps coming again. What is the cutoff? Because some have doubts when we ask. Some say 2 kg. Is it 10th percentile? Is it 2.5 kg? Is it 2.8 kg? So according to WHO, that is the guideline that we are following. And according to WHO, the birth weight less than 2.5 kg is considered as low birth weight. Please remember, students, 2.5 kg, less than 2.5 kg is low birth weight according to WHO. This is a direct question. If you know the number, you know it, and you get the right answer, you get the points or you get the marks. Okay. So low birth weight according to WHO is a birth weight less than 2.5 kg. So the answer is option 8. Option D, which is birth weight less than 2.5. Yes. So Suraj was asking if how I can repeat the Pearl index question. So Suraj, I think you have understood till here that it is 25 is the accidental pregnancies divided by the 5 is the years of exposure and 200 is the number of couples. Okay, so you multiply by 1200. I am teaching maths again. Cut the 2 zeros. Okay, and you're going to cut this 2 and here you have 6. Okay, and 5 goes here. Again, this is 5. So 5 into 6 is 30. Is that clear? It's not 20, it is 30. Suraj was telling me if I can repeat the numericals and whether it is 20. So this is how we go about. The answer is 30. Okay, I hope that's clear to you. Moving on. So we finish after Pearl index. We finish the low birth weight. Yes, 2.5. That's right. The next question, very important concept. True about iceberg phenomenon is. Okay, true about iceberg phenomenon is option A. Screening is done for the tip of the iceberg. Option B. Rabies is a typical example of disease showing iceberg phenomenon. Option C. Tip of the iceberg represents the clinical cases. Option D. Clinician usually sees the hidden part of the iceberg. Okay, so certainly before answering this question, we need to know what the iceberg phenomenon is. So students, please concentrate on the slide. There's a picture that I have put up which shows an iceberg. Okay, so an iceberg has a top visible part and there's a separation of the sea level and there's an underneath hidden cases. Okay, so the top of the iceberg is the visible part, and after the water level, here's the water level which I have marked in red, and underneath that is the hidden cases. So for diseases like the non-communicable diseases like hypertension, for diabetes mellitus, okay, for mental illness is very important. Okay, mental illnesses. Most of the non-communicable diseases, okay, non-communicable diseases, they show this iceberg phenomenon, which means that the visible cases are the clinical and the diagnosed cases, which are very few, And underneath part, which are the hidden cases, include the asymptomatic people, the pre-symptomatic people, the undiagnosed, the latent diseases, and the deliberately ignored ones, which may be true for the mental illnesses. So what is under the iceberg is totally hidden for these diseases. The tip of the iceberg is what the clinician sees and what is diagnosed. So the bigger portion is not seen. That is how the iceberg phenomenon is shown by the non-communicable diseases. Most of the communicable diseases do not show iceberg phenomenon, and if you want typical examples of disease that do not show iceberg phenomenon, I would say rabies is one. That means there's one case of rabies, it will be coming out in the community. The second one would be tetanus that I want to give example. Okay, tetanus, rabies are examples of diseases that do not show iceberg phenomenon. Do not show. Whereas these non-communicable diseases are the ones that show iceberg phenomenon. Okay. So with that idea, can we go back and see the options again so that you're able to answer me? Screening is done for the tip of the iceberg. Is it true? So screening is done for the undiagnosed, undetected cases, which is not the tip of the iceberg. It is the underneath portion. So screening is done for the underlying portion of the iceberg and not the tip of the iceberg. Okay. The second option is rabies is a typical example of disease showing iceberg phenomenon. No, I told you rabies, tetanus and most of the communicable diseases do not show iceberg phenomenon because the symptoms usually come out unless there are diseases that show subclinical infection, latent infection. During those period, they might be showing the iceberg phenomenon. But typically remember, rabies, tetanus and all do not show iceberg phenomenon. That option is wrong. Okay, the next, tip of the iceberg represents clinical cases. Yes, so tip of the iceberg represents diagnosed cases, clinical cases, and the tip of the iceberg is what the clinician sees. Okay, so option C is the right answer. Just look at option D. Yes, Suraj, you're right. Suraj, D says clinician usually sees the hidden part of the iceberg. No, it is usually the epidemiologist or the people going for screening into the field who will see the hidden part. So clinician who is sitting in the OPD will be seeing the tip of the iceberg because people come to them with the symptoms of the disease. Okay, mostly. So tip of the iceberg represents the clinical cases is the right answer. Clinician usually sees the tip of the iceberg and not the hidden part. So I hope that it's very clear. Iceberg phenomenon, the right answer is tip of the iceberg represents clinical cases. So option C is right. Now moving on to the next question. It's on an important topic which is disaster management. Okay. So all the following are true about disaster management except option A, response is in the post-disaster phase. Black color is a triage for least priority. Most common infection after disaster is gastroenteritis, and mitigation is done after the disaster. So you want to know which is the option that does not or which is not true about disaster management, because you will be facing these questions. All the following are true except. So these kind of questions are very common in the NEET PG. So you should be able to rule out the right answers and pick up the wrong one. Okay. So for that, let us talk a little bit about the disaster cycle first. Okay. Disaster cycle. So you know that disaster cycle has 4 stages. Okay, 4 stages in the disaster cycle. I would like to go from the first one as mitigation. Mitigation would be the first one. The second is preparedness. The third stage is response. And the fourth stage is recovery. Okay, 4 stages of disaster cycle: mitigation, preparedness, response and recovery. And remember, mitigation and preparedness comes before the disaster, and response and recovery comes after the disaster. So mitigation means it is actually the planning of the cities, the planning of the city and the entire town based on what disaster that area is expected to face. That is what mitigation means. Okay, planning of cities is the example for mitigation. And of course, preparedness, we do mock drills and things like that to be prepared for a disaster. All this happens before the disaster. Response is something that we take, immediate thing, the search, rescue, the emergencies, the relief. All this are the things that come after the disaster strikes. And of course, recovery is when the people are trying to come back to their normalcy after a disaster. So response and recovery, the 2 R's of response and recovery happens after the disaster, whereas mitigation and preparedness comes before the disaster. Okay, that is one concept that should be very clear for you. One more thing that I want to discuss here is regarding the triage categories. The triage categories that happen during a disaster. So, what are the color codes that comes in triage during a disaster? So, when a disaster strikes, what happens is that there will be a lot of casualty, a lot of people getting wounded. So, who should be getting top priority? People who will be benefited maximum by immediate action. Okay, people who will be benefited maximum by immediate action will be getting the first priority, which is a red color. The people who are moderately ill, okay, they can wait for some time to get their treatment. That is called medium priority, which is yellow color. And minimum with minor burns, abrasions, okay, small fractures, all these are minimum or low priority, which gets the green color. And the last, the unresponsive, the dead people, or they get the black color. Okay, black color, which means least priority. So that is how we act during a triage. We decide which category they belongs to, and immediately they will be given a tag of that color. It can be red if they need immediate response. It can be yellow if it's a delayed or medium priority. It can be green if it's minimal illness or minimal issue, and black for the least. Usually the dead and such people get the black color. Okay, so with these concepts in mind, children, do you know what the answer here is? Please put up the answers if you know. So response is in the post-disaster phase. Response, I told you the 2 R's, response and recovery, come in the post-disaster phase. So that is right. We want the wrong answer here. The first one is right. Black color is the triage for least priority. Yes, black color is a triage for least priority. The sentence is correct, but we want a wrong answer. So again, let's go to the next one. The most common infection after a disaster. So what happens after a disaster is that the water supply and the sewage and all will be mixing up usually after a disaster. So waterborne diseases are the most common infections that happen. So waterborne diseases like gastroenteritis, yes, that is true. The most common infection after disaster is gastroenteritis. And the last option is mitigation is done after the disaster. So I told you mitigation and preparedness should come before the disaster. Okay, so that is the option that we were looking for. The answer here is mitigation is done after the disaster, which is wrong. Mitigation should be done before the disaster. Okay, so that is about disaster management. We discuss a cycle, we discuss triage. Both are very important. Multiple questions can come from triage. Again, a triage alone can come as a question based on which is the medium priority or which is the least priority. That itself can come as a question. So keep revising them. Here we have got the answer. Okay, moving on to the next question. A child of 1.5 years who is 9 kg was plotted on the WHO growth chart in an Anganwadi, and the child falls between -2 to -3 standard deviation. What is the diagnosis and management of the child? Okay, so here we have a small child. The age is given, the age is given, and the weight is given. Okay, weight and age. Okay, so what is the growth chart that we are going to look into? Weight for age growth chart. Okay, students, weight for age growth chart is what we are going to look into. I have a picture of that. So the child here falls between -2 to -3 is what is told. Let us see where the child will come, or what color is the child going to fall into in this growth chart. So I hope you can see my growth chart. This is the growth chart for a male child, because you can see this is blue color. If this is pink, it becomes for girls. This is the growth chart for boys. Weight for age growth chart, okay, which is seen in the Anganwadi. So as you can see, this green color is what is called as the road to health. Okay, road to health, which means the child should come within this area. This is the best. That is 0 to -2 standard deviation is the green color. Okay, 0 to -2 standard deviation. 0 to -2. -2 to -3 is the yellow color, which means the child is having moderate malnutrition. So yellow means moderately malnourished or moderately undernourished. Okay, yellow, that is -2 to -3 standard deviation. That is yellow. Whereas the red means that it is below -3 standard deviation. Below -3 standard deviation is severe acute malnutrition, which is called SAM. Okay, severe acute malnutrition, we call it as a SAM child. If the plotting of the weight and the age of the child falls into the red category, what is it called? It's called a SAM child, which means severe acute malnutrition. And the SAM children are usually managed at a place called Nutritional Rehabilitation Centers or NRCs. Okay, so SAM children less than -3 standard deviation managed in NRCs. Whereas yellow, that is -2 to -3 standard deviation, is moderate malnutrition. They will be usually advised as to what can be done at home to improve the nutritional status. Okay, so that is the idea that we have. Green color, yellow color, red color. So I hope you are with me, guys. You can understand what each one is. Green is the best that we should have. The child is normal if it's in the green. That means 0 to -2 standard deviation is normal. -2 to -3 standard deviation is yellow, which is moderately undernourished. And less than -3 is red, which means severe acute malnutrition or SAM. SAM children are sent to NRC or Nutritional Rehabilitation Center, whereas moderately malnourished children, we advise their mothers as to how they can come up in the chart and go into the green. So with this idea, can we answer the question? Please put up the answers, those who know them. Even if it's a mistake, we can always correct it. So please put up your answers. So the options here is the child is healthy, no intervention required. If the child is falling between -2 to -3, the child is certainly not healthy because the child is having moderate malnutrition. Yes, the child is having moderate malnutrition, so not healthy. So the first option is out. Second option, the child is moderately undernourished. Yes, that's right. But the second part of the option is refer to NRC. Oh no. Whom will you refer to NRC? You'd refer a SAM child to NRC. But ours is not a SAM child. So the option is wrong. The third option is child is Sam, advise the mother. No, the child is not Sam. The fourth option, child is moderately undernourished, is right, and we're going to advise the mother. So the answer is option D. I hope that is clear. Yes, Simran is trying. So the second option is child is moderately undernourished is exactly right, but the second part, please read, refer to NRC. No, you do not refer a moderately undernourished child to NRC. NRC or Nutritional Rehabilitation Center is a place where SAM children go. For moderately undernourished, we usually advise the mother. So that is the answer. Please be familiar with the growth chart. What are the standard deviations? What are the color codes? And what does it mean? Because it's a very important question. Moving on to the next question. The child is moderately undernourished. Yes, Simran, you're right. But please recheck the option again because we have discussed already. Okay, the 13th question. On measuring the height and weight of a child attending the Anganwadi, the teacher noticed that the height for age of the child is less than -2 standard deviation. Okay, so here we have something called height for age of the child less than -2 standard deviation. Okay, so what does this signify is what we want to know. So here you must understand that there are weight for age growth charts, weight for age, height for age, and also weight for height. These are the three things that we usually calculate in under 5 children. Weight for age, height for age, and weight for height. What happens if each one of this is low, or how is the interpretation is what we need to know. So what happens if the weight for age is low? So when a child is low weight for age, that is what we had discussed here. It is malnutrition. Okay, it can be acute or chronic malnutrition. The child is just underweight. It can be an acute or a chronic condition if the weight for age is low. But when the height for age is low, that means it is chronic malnutrition, and the term that we use for low height for age is stunting. Okay, so when a child has chronic malnutrition, the child will be stunted and he will have less height for age. The third one is weight for height. So weight for height, when it is low, it means that the child is having acute malnutrition which results in wasting. Okay, so please be clear about this. For low height for age, it is chronic malnutrition which is called stunting. For low weight for height, it is acute malnutrition which is wasting. But when it is weight for age is low, it is just malnutrition. It can be acute or chronic. It's also called underweight. Okay, so let's go back and see what option is going to come as a right answer. Yes, option A is chronic malnutrition. So I told you, when height for age is less than -2 standard deviation, which is low, there is chronic malnutrition. Okay, that means there is stunting for the child. That is the right option. Please learn this properly. What happens, or what is the term used for low height for age, low weight for height, and low weight for age. These are important concepts that keep coming for exam. Okay, so that was option A, the answer. Now moving on to the next question. The 14th question is, a primary health center shows 50 to 60 cases over a week. The following week had 54 cases in total. This is called, option A is sporadic, option B is endemic, option C is epidemic, and option D is outbreak. Okay, so here you need to know concepts of epidemic, endemic, sporadic, and outbreak, so that it's a direct question if you know that. So sporadic means a disease occurring on and off in certain sites in a geographical area. Okay, like it will be scattered here and there in an area, then it is sporadic case. An endemic case is something that is constantly present in a geographical area at a particular time. Okay, so fever or any case of common cold, there are certain numbers that are expected in a geographical area and that will be constant throughout. That is called endemic. Whereas a disease is called as an epidemic. What happens is there is excess in number of the cases or the health issue than what is expected in the geographic area. So there will be a usual occurrence of a few numbers, but the coming week the numbers may be doubling or much more than the expected range. That means it's an epidemic, and when it's in a smaller population it is called an outbreak. Okay, so what happens is a PHC is showing 50 to 60 cases in a week. Usually, that means this is the average number in that area over a period of time. And the following week had 54 cases. So 54 is a number that falls in between, right? 50 to 60. So what is the answer that you're expecting? It is a constantly present exactly in the numbers that we are expecting, which means that this is called an endemic disease. Now, suppose I want to tweak the question and say the following week had 100 cases of this disease, then the answer is going to change. It will become an epidemic. Okay, it will become an epidemic. And if the population is described, if it's a smaller population only, then we go into outbreak. But if the number is going to double and if it's going to be really high, then we say it's an epidemic. But here the answer is endemic because the number was 54, which was falling into the average of 50 to 60 cases. So endemic means that disease is present in the population constantly in an expected range. Okay, so that is an endemic. Hope that is clear. The answer is answer B. Moving on to the next question. The 15th question is, the Global Hunger Index includes which of the following? So again, Global Hunger Index is a very, very important topic and it keeps updating every year. Okay, so the numbers and things like that. So it has to be updated. So when I'm talking about the 2022 details of Global Hunger Index or the latest values. Okay, so Global Hunger Index includes which of the following? Infant mortality rate, under 5 mortality rate and undernutrition, that is the A option. Option B is under 5 mortality rate, child undernutrition and child undernourishment. Option C is infant mortality rate, child undernutrition and child undernourishment. Fourth option or option D is infant mortality rate, maternal mortality rate and child undernutrition. Okay, so the basic idea that I want to present here can be told as a small story. Like there might be a child, there's a child who is not getting food. Okay, no food supply. That means very poor, no food. So the child is going to go into undernutrition or malnutrition. Okay, undernutrition or malnutrition. And finally, the child is going to face death or before the age of 5 years. Okay. Because of severe undernutrition, the child is going to die before the age of 5 years. Just remember this as a story. This is a small child with no food supply. The child is going into malnutrition or undernutrition. The child is going to die of undernutrition before the age of 5 years. So here we have three concepts: no food supply, undernutrition and under 5 mortality. Okay, so that is what Global Hunger Index is. I hope you can see my picture. The three composition or three dimensions of Global Hunger Index is inadequate food supply, child undernutrition and child mortality. These are the three dimensions of Global Hunger Index. Okay, three dimensions. So that is easy way to remember is just remembering that the story of a child. So no food supply, child is undernourished, and finally child mortality or under 5 mortality. Now, other than 3 dimensions, Global Hunger Index also has 4 indicators. So, if they are asking the indicators of Global Hunger Index, what are they going to be? The first one is again undernourishment. Okay, undernourishment, which is what the first point is. Without the food supply, the child is undernourished. Undernourishment. The second indicator is going to be under 5 mortality. Okay, under 5 mortality. The third is going to be wasting, and the fourth is going to be stunting. Okay, so this wasting and stunting will be part of child undernutrition. Okay, so your first undernourished child is going to fall into undernutrition, which is wasting and stunting, and finally death, so under 5 mortality. So these are the 4 indicators of Global Hunger Index: undernourishment, under 5 mortality, wasting and stunting. Please remember, it's very important, the 3 dimensions and the 4 indicators of Global Hunger Index. And I also want to stress that in 2022, you need to know this, in 2022, India has ranked 107 Global Hunger Index out of 121 countries, which means we are behind. Okay, we need to go up. We are behind in the Global Hunger Index. Our rank, India's rank is 107 out of 121 countries, and our score was 29.1. That means we are still having serious hunger in our country. Serious hunger. 29.1 was the score of India, and the rank was 107 out of 121. Please remember these numbers, students. This is the numbers for 2022, which is the latest. Okay. Okay, so can we go to the question and identify? Now it's become very easy for you, since you know the story. You can easily tell me which the answer is. Less food supply means child undernourishment, and then the child is undernutrition, and the child is going to die before 5 years, so under 5 mortality. So the option is option B. Global Hunger Index includes under 5 mortality, child undernutrition and child undernourishment. This undernourishment can also be told as decreased food supply. Okay, so students, I hope you're still with me. You're answering the questions. Good. Please keep going. We are moving on to the next question. So the next question is, acute encephalitis cases are reported among people from Bilaspur, Chhattisgarh. Mass vaccination was planned by health authorities. Which type of vaccine is delivered here, and also mention the route of administration. Okay, so here we have a case of acute encephalitis. So among the vaccine preventable diseases, which disease are we looking at? Which disease do we have? Which encephalitic disease do we have mass vaccination? The one that we can think of is usually Japanese encephalitis. Students, we are referring, when you say acute encephalitis, we are referring to Japanese encephalitis. Okay, so you need to know the type of vaccine and the route of administration here. So we have live vaccines and killed vaccines in our immunization schedule, and the routes are different. So Japanese encephalitis is actually a killed vaccine, and 0.5 ml is administered subcutaneously to children in the endemic areas only. Only in the endemic states we give Japanese encephalitis. That is very important. Okay, which are the endemic states? Karnataka, Tamil Nadu. There are many states, but very common: Karnataka, Tamil Nadu, UP, Assam. Okay, these are examples of states which are giving Japanese encephalitis vaccine because this disease is endemic. Those countries, those states which do not have the disease, they do not have the vaccine in the schedule. So I told you this is a killed vaccine and it's given subcutaneously. So our option is option D. Japanese encephalitis is killed vaccine given subcutaneously. And we can also discuss the national immunization schedule quickly, because that is the concept behind. Okay, so what are the vaccines given at birth? BCG, OPV and hepatitis B vaccine. Students, I hope you're with me. The national immunization schedule is very important. There will be questions coming from this. Okay, BCG, OPV and hepatitis B birth dose are the vaccines given at birth. At 6 weeks, we have lot of vaccines. We have OPV, we have pentavalent, we have Rotavac first dose, fractional IPV first dose and pneumococcal conjugate vaccine first dose. Please remember, out of this, OPV and rotaviral vaccines are given orally. Okay, that is at 6 weeks. The same vaccines at 6 weeks will repeat at 14 weeks, if you can notice. Okay, but at 10 weeks, a little different. We do not have the pneumococcal vaccine and the fractional IPV at 10 weeks. We have OPV, we have penta and rotaviral vaccine at 10 weeks. Okay, so after birth, the child comes at 6 weeks, 10 weeks, 14 weeks. Now the child is going to get a break. Okay, then the child is next going to come at 9 months. Okay, 9 months, what are they going to get? MR vaccine, JE, that's what we are discussing here. Okay, JE first dose is going to, the child is going to get at 9 months, and there's also a PCV booster at 9 months. And recently the national immunization schedule has added one more dose of fractional IPV at 9 months. So this is a recent update, students. Please remember, new dose of booster dose of fractional IPV given at 9 months. It's an additional to national immunization schedule. Okay, so after 9 to 12 months, the next is at 16 to 24 months, where we have MR second dose, JE second dose, DPT booster and OPV boosters. Then at 5 to 6 years, the child gets DPT booster again. Then again at 10 and 16 years, the child gets TD vaccine. Okay, so that is the national immunization schedule. Here we were talking about the JE vaccine, that is at 9 months, the first, and the second dose at 16 to 24 months. But the important thing is that they are given only in the endemic states. Okay, endemic states. So the answer was that it is a kill vaccine that is given subcutaneously. That was the answer. Okay, moving on to the next question, the 17th question. A 50-year-old male presents to the OPD with the following skin changes. What significant history should you take from him? So you have a picture. Please identify what is the picture. It's a very important one. What is the picture showing? This is something called Castle's necklace. What is it? What is Castle's necklace? In which disease are we getting this? Castle's necklace. Okay, anybody, if you know, please put up in the chat box. This is seen when there is vitamin B3 deficiency. Vitamin B3 is niacin. Okay, in niacin deficiency, we see Castle's necklace, and also there is a tetrad that we should learn. Tetrad. Okay, a tetrad of 4 Ds. 4 Ds. What are they? Diarrhea. Okay, diarrhea, dementia, dermatitis, and the last one is death. Okay, so the person is going to get worse and is going to die. So 4 Ds are the tetrad of niacin deficiency. What is the disease called? It's called pellagra. I hope you know that, right? Pellagra. Okay, pellagra is the disease where it shows 4 Ds, and you need to also identify the Castle's necklace, so that what significant history should you take from them? We are looking for the 4 Ds. So diarrhea, dementia, dermatitis and death. You have the options of diarrhea and dementia. So the answer is option B. Very important question, repeat question. There's a picture, so there's very high chance that such questions keep coming in the exam again and again. So Castle's necklace, tetrad and niacin deficiency. So the answer is option B. Moving on to the next question. A 2-year-old child comes unvaccinated, comes to the PHC for immunization. What are the vaccines that can be given to the child? Okay, what are the vaccines? Students, if you know 2-year-old child, what vaccines can be given to the child if the child is totally unvaccinated? So here we need to have a concept of the child coming to the OPD who is less than 1 year totally unvaccinated. Okay, unvaccinated children, yes, we still see them. So if the child is less than 1 year, what vaccines can be given? If the child is 1 to 5 years, what vaccines can be given? If the child is above 5 or 5 to 7 years, what vaccines can be given? Here we need to have a clarity. Okay, so unvaccinated, less than 1 year, lot of vaccines can be given. BCG can be given, the Pentavac can be given, OPV, IPV, MR, rotaviral vaccine, Japanese encephalitis in endemic areas, plus vitamin A, which is a supplementation. So that all these can be given if the child is less than 1 year, but of course it's important that the vaccine should be spaced. Okay, so 2 live vaccines especially should not be given in the same arm, they should be given in the opposite arms, and other injectables should not be given in very close spaces, they should be spaced. Okay, so less than 1 year unvaccinated child, these are the vaccines that can be given. If the child is 1 to 5 years, we can give DPT, we can give OPV, we can give MR, we can give JE in endemic areas, and vitamin A. So please remember, Penta is ruled out, BCG is ruled out, okay, IPV is ruled out, Rota vaccine is ruled out. Okay, from 1 to 5 year old child, DPT, OPV, MR, JE in endemic areas, and vitamin A. These are the vaccines that can be given if the child is totally unvaccinated. Now if the child is more than 5 years or 5 to 7 years, only DPT's vaccine can be given. The first, second and the third doses can be given at a spacing of 1 month each. So students, from this, please tell me what is the answer to the question. What is the answer? Here the child in our question is 2-year-old unvaccinated child. So which category is it coming? The child comes into the second category. So we can give OPV, DPT, MR, JE. Let us look at our options. The first option, BCG, OPV and DPT. No, because BCG cannot be given to this 2-year-old child who is unvaccinated. That's not the option. The second option is OPV and DPT. Yes, DPT can be given and OPV can be given. Okay, so option B will be the right answer. Let us look at the other 2 options also. We have pentavalent in both the options. So Penta cannot be given to an unvaccinated child above 1 year. So both the options of C and D are ruled out. The answer is option B. So please learn this concept of what a child, an unvaccinated child less than 1 year can get, 1 to 5 years can get, and what child more than 5 years or 5 to 7 years can get. Okay, I hope that is clear. Are you with me? Please put up your answers so that I know you are still here and I'm continuing my session. Okay, the next question. A study values with normal distribution had median as 300 and standard deviation as 20. 68% of the data will fall into which of the following? So here the concept that we are going to discuss is normal distribution. Okay, very important. There's a diagram that I want to show you. Okay, so this is the curve of normal distribution, which is called as the bell-shaped curve. Okay, bell-shaped curve. If the data is normally distributed, we get a bell-shaped curve like this. And as you can see, the +1 and -1 standard deviation, +2, -2, and there's also +3 and -3 standard deviation. And what is meant here is that 68% or 68.26% of the values of our data will fall in between one standard deviation. Okay, between -1 to +1 standard deviation will be 68.26% of the data. Between -2 and +2 standard deviation will be 95.4% of the data, and between -3 and +3 standard deviation will be 99.7% of the data. This is something that you must learn, must by heart. Okay, students, 68.2% between -1 and +1 standard deviation, 95.4 between -2 and +2 standard deviation, and 99.73% of data between -3 and +3 standard deviation. So this is the concept that we need to answer this question. So here they've asked 68% of the data will fall into which of the following ranges. Okay, so 68 we know is between -1 to +1 standard deviation, right? So here you know that the median is 300 and standard deviation is 20. So in order to get -1 standard deviation, what will the value be? 300 minus 20, which is 280 is the lower range. Okay, to 1 standard deviation is +1 standard deviation is 300 plus 20, which is 320. Okay, so we get 280 to 320 as -1 to +1 standard deviation, inside which 68% of the people or the data will be falling. So we have the answer as option A, 280 to 320. I hope that is clear, students. Normal distribution and the percentages into which the +1 to -1 standard deviation falls, +2 to -2 falls, and +3 to -3 falls. You need to by heart these percentages so that you can answer such questions in the exam. Okay, so the option is option A. I hope that is clear. I hope all of you are with me. Okay, so the next question is a very direct question, very easy. If you know it, you get the 4 marks quickly. Where is the headquarters of UNICEF located? Okay, so we need to know the headquarters of a few places. Starting with WHO, where is the headquarters of WHO located? It is in Geneva. Okay, Geneva, WHO headquarters. Similarly, ILO, International Labour Organization, is also in Geneva. The next one, Food and Agricultural Organization, FAO. Where is the headquarters of FAO? It is in Rome. Okay, it is in Rome. The next important international organizations that we need to know are UNICEF, UNDP, okay, and UNFPA. All these are important international organizations. The headquarters of all these fall in or come in New York City. Okay, New York. So this is just a simple basic question. If you know the headquarters of these places, you get the answer. Students, so what is the answer to the question? Where is the headquarters of UNICEF located? Please tell me the answer. Please put the answer in chat box. Okay, so the headquarters of UNICEF is located in New York. Okay, the answer is option D. Okay, I hope that's clear. Very simple question. Headquarters of UNICEF is located in New York City. Moving on to the next question. According to the biomedical waste guidelines, gloves are disposed in which color bag? Option A, white, option B, red, option C, yellow, and option D is blue. So in order to understand this, you know that we have to study the color coding of the biomedical waste treatment. So first of all, I will tell you what are the color codes that are available. If there are people who know the answer already, you can put in the chat box. So the color codes available in a hospital or for disposal of biomedical waste are: yellow is the first color, second is red, third is the white, which is a translucent puncture proof container, not bag exactly, and the fourth one is actually blue color, blue cardboard boxes. Okay, so yellow, red, white and blue are the four categories of or colors of biomedical waste segregation. Okay, those are the four colors that you need to know. The yellow is plastic bag, red is also non-chlorinated plastic bag, but whites are puncture proof containers. Okay, you need to know that whites are puncture proof containers and blue are cardboard boxes. Okay, blue colored boxes. So what goes into each of these? This is very important, students, the type of waste that goes into each of the color coded bins, because this is what keeps coming for exam. They keep tweaking the thing that you're going to put. They'll ask what happens, where does gloves go, where does placenta go, where does soiled cotton go, tubings go. So these keep coming for exam. So please be very clear. Those who know the answer, please put up in the chat box so that I know you're here. Okay, so the type of waste that goes into the yellow container are human anatomical waste. Human anatomical waste means any part of that comes out after a surgery, like again a placenta or a uterus, after a biopsy. All those materials are human anatomical waste, which goes into the yellow container. Animal anatomical waste goes into the yellow container. Soiled waste, which means your cottons which are dipped in biological fluids, soiled with either blood or any fluid, goes into the yellow container, yellow bag. Okay, expired or discarded medications, again this was a previous year's question. Expired or discarded medications go into the yellow yellow bag. Chemical waste, micro, bio and other clinical lab waste, and chemical liquid waste, all these go into the yellow bags. Okay, then we have the contaminated or recyclable waste. Okay, recyclable plastics like IV bottles, IV tubings, catheters, urine bags, syringes without needles, and gloves. Very important, gloves, it goes into the red bag. The next is sharps. All the sharps go into translucent or puncture proof container, and the glassware, that is all your ampules, go into the blue container. So this is the type of waste that goes into each of the biomedical waste color codes. Okay, so yellow, red, white and blue, and what type of waste go into each of these. So can we go back to the question? It's a very simple one now if you know the concept. So gloves is what is asked. Gloves is recyclable plastic which goes into the red bag. Okay, so the option is option B. Okay, red bag. So gloves go into the red bag, students, recyclable plastic waste. So hope you're clear with that. Next question. All are true about JSSK except. So JSSK is a program under the Ministry of Health and Family Welfare. We will discuss about that. What are the facilities under that? So all are true except free delivery facility, free diet for the mother during hospital stay, free treatment for sick infants up to 3 months, free transport from home to hospital and back. So in order to understand, we need to see what JSSK is. So like I told you, it is, the full form is Janani Shishu Suraksha Karyakram. If you can see in my slide, JSSK. Okay, it is under the Ministry of Health and Family Welfare, and it was introduced in 2011 in order to decrease the out-of-pocket expenditures for pregnant women and their sick children. Okay, that was the idea. When it was introduced in 2011, they wanted to bring down the out-of-pocket expenditures for pregnant women and sick children. Okay, so what all did they get? They got free delivery plus stay, that is including cesarean section. Okay, stay with food also. So food was 3 days for normal delivery and 7 days for cesarean section. Okay, so free delivery, stay and food, that was one facility. Free drugs, diagnostics, okay, which means the laboratory was free, and also blood transfusion free of charge. Okay, then they got free transport, that is from their home to the hospital, as well as they will be dropped back after delivery to their home. Okay, that means to and fro transport plus a referral if required. A referral transport was also free. Then any complications of antenatal or postnatal visits were considered given free of cost. And finally, free treatment of sick infants up to 1 year. So these were the facilities given or the provisions under JSSK. So once again to repeat, free delivery, stay and free food for 3 days in normal delivery, for up to 7 days in cesarean section, free drugs, free diagnostics, free blood, free transport to and fro from home, as well as a referral transport was free, antenatal and postnatal checkups, and their complications were also dealt freely, treatment, and treatment of sick child up to 1 year was free of cost under JSSK. So what is the answer, students? Please comment the answer. Option A is free delivery facility. Yes, it was there. Free diet for the mother during hospital stay. Yes. Free treatment for sick infant up to 3 months. What is the answer? No, it is not 3 months. It is up to 1 year. It was free. So that is a wrong answer. And free transport from hospital and back is true. So here we wanted the wrong answer, which is option C. Okay. JSSK, very important program under the Ministry of Health and Family Welfare. Please understand. Okay. The next question, the 23rd question, is regarding the first referral unit or the FRU in India. So again, we need to know what are the provisions under a first referral unit. So I just want to say that there are 3 critical determinants to say that a hospital is first referral unit. Okay, 3 critical determinants. The first one is surgical interventions should be present. Surgical intervention, that means an OT with anesthetist and other technicians. Okay, anesthesia and technicians. Second one is newborn care should be available. Newborn care means there should be a pediatrician and there should be facilities for newborn care. And third critical determinant is blood storage facility. So if these 3 are there are all the facilities for emergency obstetric care should be there in a first referral unit. Emergency obstetric care should be there in a first referral unit. But the 3 most critical determinants are what I am telling you: surgical intervention, newborn care and blood storage. So if we can look into the options, the first referral unit in India, the option A is primary health center and district hospital. So all of you know that a primary health center has only OP facility. There is no surgical intervention. There is no blood storage. So that is ruled out. Again, the second option also, there is PHC. So as soon as you see that itself, you can rule out. The third option has sub-center, which is even the lower level than PHC. There is no blood storage or surgery. So that is ruled out. So the answer or the possibility here is a community health center and district hospital, which is the last option, where there will be facility for surgeries, newborn care and blood storage. So first referral unit, very important, students. I hope you are with me. The answer is option D, CHC and district hospital come under the first referral unit. Okay. The next question is regarding surveillance in malaria. Okay, a male health worker collects blood for malaria surveillance in community every 15 days. What type of surveillance is this? So before we go into the answer, we need to know that there is something called active surveillance. There's something called passive surveillance. Okay, then there is sentinel surveillance also. So active surveillance is actually provider initiated. That means somebody is going into the community, okay, provider initiated, it is more helpful one, okay. It helps in picking up more cases, active surveillance, provider initiated. Whereas passive surveillance is the thing that we do in OPDs and in the hospital when people are coming to you. So it is actually the requirement is for the patient. The patient is coming to the OPD and or hospital, and we are recognizing the cases and identifying them. That is passive surveillance. Whereas sentinel surveillance can be active or passive. Okay, it can be active or passive, and it is actually done for the missing cases. Okay, for the missing cases, to get the missing cases we do sentinel surveillance. Like for example, for malaria, the cases may be missed in bigger private hospitals. Okay, in private hospitals the malaria cases or the deaths may be missed. So there are sentinel surveillance units for malaria in multiple private hospitals. Okay, so sentinel surveillance is to detect missing cases. It can be active or passive. And active is when provider initiated, somebody going into the community. Passive is when we sit in our OPD and people are coming to you and you're recording the cases identified. So all these types of surveillance are done for malaria. So here the question is regarding a male health worker who goes into the community every 2 weekly to identify malaria cases. So what kind of surveillance is that when a person goes into the community? That is active surveillance. Okay, that is active surveillance. So it's a very easy question if you know the difference between active and passive surveillance. Answer is option A. Okay students, any doubts? You're not putting up the answers in the chat box. Please do that so that you also get practice to the MCQs. So my last question for the day is regarding the syndromic management of STDs. Syndromic management. Okay. The question is, STD kit for a female with vaginal discharge is option A, kit 1 grey, option B, kit 2 green, option C is kit 3 white, and option D is kit 4 blue. So before we go into this, we need to know that there are color coded kits for the syndromic management of STDs. I can show you the picture. Okay, so whenever patients come for sexually transmitted diseases and their treatment, we have to identify or classify them into one of these, whether they have urethral or anorectal or cervical discharge is one. Okay, the second is vaginal discharge. The third condition is genital ulcer. So genital ulcer can be non-herpetic or herpetic. Okay, so genital ulcer, non-herpetic, in patients who are not allergic to penicillin will get a white kit, but genital ulcer patients who are allergic to penicillin will be getting another color kit, which is blue. Again, genital ulcer disease, if herpetic, is a totally different kit. Then lower abdominal pain, which is very common in women, it might be diagnosis of pelvic inflammatory disease, they get a yellow color kit. And the last one, if there's an inguinal bubo, they get a black colored kit. So urethral or anorectal or cervical discharge is grey colored kit. Vaginitis or vaginal discharge is green. Non-herpetic genital ulcer in patients who are not allergic to penicillin is white because it has penicillin as a content. Then genetic ulcer in patients, non-herpetic type in patient allergic to penicillin will be blue colored kit because the kit does not have penicillin. Again, genital ulcer disease for herpetic type is red colored kit, and for PID and lower abdominal pain is yellow kit, and inguinal bubo is black kit. So you need to learn what colors each kit is, and also you need to learn what drugs are present in each of these kit. Only then your study is complete. So grey colored kit is tab azithromycin 1 gram and cefixime 400 mg. So there are just 2 tablets, azithromycin and cefixime in the grey kit. Green kit is secnidazole and fluconazole, again 2 tablets. White kit is little more complicated because there's an injection, as you can see, benzathine penicillin. There's also azithromycin 1 gram. Okay, and then there will be consumables which are required for dispensing this or giving this benzathine penicillin. So basically penicillin and azithromycin in white kit. In blue kit it is doxycycline and azithromycin. In the red kit it is acyclovir tablet alone. Okay, but this is for 7 days as acyclovir tablet. For PID we have cefixime and metronidazole and doxycycline. So this is a kit that contains 3 medications. Okay, 3 medications, yellow. Whereas black kit has doxycycline and azithromycin alone. So please students, go through this color coded kits for syndromic management and learn the colors, learn the drugs that are present in each one very clearly, so that as soon as you see the question, you are able to identify which kit is required and what is the drug inside that. So with this idea, can we go into the question again and identify the answer? So this is vaginal discharge. I was talking about vaginal discharge or vaginitis. So it is kit green, which is the second colored kit. Okay, second colored kit was the kit for vaginitis or vaginal discharge, which has secnidazole 2 gram and fluconazole 150 mg. So that was the answer to our last question. Okay students, so this is a very important concept. Please make sure you know the syndromic management of STD with the answer to this question also, with the tablets inside each kit. Okay, so that's it from my side. I hope you have understood all the 25 questions and the concepts behind the same. If you have any doubts, once again feel free to put in the chat box, and please keep answering the questions like you were doing initially. Thank you.